All right. We've got here today potassium, right? Serum electrolyte, super important for cardiac function, muscle function, and it has plenty of other roles in the body as well. Okay. It's an intracellular cation, meaning think about it like this. If potassium is found on the periodic table, well, it has to have protons, neutrons, and electrons, right? Which is one of the ways, excuse me, that it'll help you understand on how it gets into the intracellular fluid to the extracellular fluid. We operate on a molecular level. So how is this all related to what you're going to see in your patient? I've put together this board for you. It kind of looks like a whiteboard like we have in the classroom here. Let me make this a little bigger so you guys can see it. Let's follow through here. I've prepared this in such a way, hopefully this will explain it a little bit easier for you, okay? So you have potassium. Potassium will alter the body. It'll either put you into an acidotic state or an alkalotic state because of its exchanges with bases, with hydrogen. Okay, so again here, depending on the pH of the body, calcium and hydrogen, they basically go at war with each other in the kidneys. Okay, in the tubules. Which one's going to be eliminated? That's what they argue about when it's there. So if you follow here, before I even get to whether hypo or hyperkalemia, I want to discuss it a little bit further. Potassium and hydrogen can also be exchanged at a cellular level in acidosis and alkalosis. Well, how does this all relate to each other? Here we go. Increased potassium levels stimulate aldosterone release from the adrenal gland. This is the property or the function that promotes potassium loss in the urine. Okay. Once we can understand that aspect of potassium, we can move forward here. When the body undergoes changes in potassium in the balance of, think about homeostasis, right? The way the cells are, the way their excitability changes, the ability of the cells to fire, means cells will fire excessively with little stimulation, or they'll barely respond to stimulation. Hopefully this will the effect of changes in potassium level are seen both in the skeletal and cardiac muscle tissues. All right. One other thing, so potassium, like I said, is an intracellular cation or electrolyte. Okay. It's also the primary buffer in a cell. Normal potassium level is 3.5 to 5, right? It's in the food we eat, it's in some of the drinks that we consume. Okay. It moves basically in and out of cells. It travels to a few areas in the body, meaning blood, urine, GI fluids, sweat, saliva. It's in chyme. Okay. Again, changes in the body. Insulin will actually negate changes in potassium, which is definitely an interesting topic. Adrenal hormones and sodium levels. Okay, and that's because of the channels and the pumps that are found within the cell, but that's on a whole nother level. So let's get into hyperkalemia. Okay, excess potassium. Well, why would we have so much potassium floating around in the blood? Here we go. Renal failure, right? We can't excrete the potassium, so it's sitting there in the body, it's building up, and it might get to a toxic level. That's problematic. Too much potassium upon administration, possibly during a hospitalization. Okay, traumas, burns, crush injuries, heart attacks, depending on the type of surgery. Now remember, On the other spectrum of hypokalemia, we would lose potassium in vomiting and in diarrhea. Okay, so but back to hyper or excess potassium in the body, hemolysis of your red blood cells, acidosis, for example, DKA. We had a patient where a student was unfortunate for the patient, but fortunate for the student nurse that they actually got to see DKA at the clinical site. And it was quite amazing because we were able to correlate book knowledge with the visual aspect of it. What else can give you hyperkalemia or an increased amount of potassium in your blood? Addison's disease. Potassium sparing diuretics, which antagonized aldosterone. Okay, that's the key. Salt substitutes. Yeah, people that, especially patients with renal compromises, something that we could teach as nurses is to avoid um, um, potassium salt substitutes. It's commonly found on the shelf in the store. People think that they're doing themselves a service by using a salt substitute, but really they're increasing their potassium. And that's really not a good cocktail, because if they're at home and they're eating other potassium rich foods and maybe also take NSAIDs or something else that will contribute to renal dysfunction and or dehydration, if they're undergoing dehydration or if they're out doing an activity without replenishing, that could create a problem. Okay. Being insulin deficit, having an insulin deficit, or in hemorrhagic shock, right? We're losing volume, we're losing blood, we're losing nutrients. How is your patient gonna look, right? Uh-huh. Well, if we objectively can measure hyperkalemia, it's going to be where the potassium is over that maximum range. Remember, 3.5 to 5, depending on your textbook. Okay. Evolve and Elsevier says, hey, if you've got a K level 5 or above, typically 5.5 and above, you're going to see some of these changes here in the box. Bradycardia, right? Dysrhythmias, cardiac arrest, generalized muscle weakness, malaise, right? That's the flu-like feeling symptoms. Flaccidity, paralysis. That could also lead to respiratory problems. Nausea, diarrhea. You'll see changes in the EKG, cramping, abdominal cramping, hyperreflexia, numbness, tingling, metabolic acidosis. They could be in a couple of phases here, oliguric or anuric, right? Should know those definitions as well. Let's go a little bit deeper though. So cardiac changes, right? What are you going to see? What kind of changes you're going to see in the heart? Yeah, a sluggish heart muscle, right? Bradycardia, a slowed SA and AV node. Remember, the SA node operates 60 to 100. The AV node operates 40 to 60. Okay, you're going to see those conduction changes with excessively high potassium. What else are you going to see? Tall and peaked T waves. You might see a depression in the ST segment, a prolonged PR interval. You're going to see a flat or absent P wave, widened QRS. That's probably one of the earlier signs. I remember seeing those on the floor as well. Prolonged QT. We don't like that because that can potentially lead to cardiac arrest. And VFib, right? For VFib, we defib, but we don't even want to get to there. So those are some of the changes you may see. Signs Signs you'll see, because symptoms is something subjective. Nausea, right? Subjective. Let's keep going down here. Now, following along in this explanation here, let's go this way. Let's go to the other side of the world here. Hypokalemia, right? This could happen because of some excessive fluid loss, like I was saying earlier, diarrhea, NG tube suctioning, vomiting, diuretic drugs like loop diuretics, hey, Lasix, inadequate intake of potassium-rich foods, which also have to coincide with abnormal losses. One we typically look over, unfortunately, is wound drainage, right? Fistulas, loss of potassium in the urine when the kidney does not reabsorb it. Remember, I was saying that hydrogen and potassium like to fight in the tubules, right? Who's getting eliminated? If we're losing it, we're not reabsorbing it, it's not coming back into our cells. Diuresis, right? Because what happens when diabetes mellitus type 2 is uncontrolled? We have polydipsia and polyuria, right? Excess aldosterone secretion, also called hyperaldosteronism. Excuse me, malabsorption syndrome, malnourishment. Of course, what we're talking about here in acid-base imbalance, your heart failure patients, right? Because sodium and water are best friends. And when we retain sodium, water comes with us. When we retain water, sodium comes along for the ride and we get rid of potassium. We just throw it out. Boop, bye, potassium. Okay. Also, latex, laxative abuse. People with certain mental health or eating disorder conditions may take access laxatives, or maybe even accidentally take it. Who knows? There's many reasons why people put themselves on laxatives. It is over the counter, OTC. So when we have excessive elimination of fecal matter, we're going to lose potassium. Okay. Well, diarrhea, we're going to lose potassium. That's the key word, is the diarrhea part. Okay. Being NPO, right? Not eating. Trauma, intravenous insulin and glucose. Yep. And what's the only insulin we can put through an IV? That would be regular, right? Reaction to stress, meaning excess adrenocortical hormone secretion, right? All those on a cellular pathway will decrease your potassium, your serum potassium. So now that we discussed some of the reasons or etiologies, let's discuss the findings. What it's going to look like. This is typically when they're below 3.5 or less. That's why when we get a potassium level in the hospital of 2.9 or 2.8 or 2 point something low, we're on the phone with the doc and we're initiating a K-MAG protocol. Normally when K is low, MAG will follow. Okay, you need both of those. So again, so here you're going to get generalized muscle weakness, malaise, you're going to get some paresthesis, numbness, right? Again, here too, you can get cardiac arrest. Could also enhance the effects of digitalis drugs, digoxin, digitoxicity, right? It's going to present as a decreased or absent reflexes. Normally starts in the lower extremities. Abdominal pain, vomiting, nausea, anorexia. Reduced intestinal peristalsis, intestinal distension with gas, a paralytic ileus, decreased blood pressure, and metabolic alkalosis polyuria, as discussed. Now, those were the typical findings of hypokalemia. But now let's talk about it on an EKG level. What's going to happen, right? Forceful contractions and weak pulse. Changes in the EKG, flat or inverted T waves. You'll see U waves, a depressed ST segment, tall P waves, a prolonged PR interval, and a wide QRS. You might see PVCs as well. What we don't want, VFib, and we definitely don't want cardiac arrest. You might see SVT or ventricular ectopic beats. Increase the risk for digitalis toxicity. Here's the thing, low potassium makes the heart muscles more sensitive to the action of this drug, okay? Keep that in mind. All these helpful hints when thinking about potassium, right? Because hopefully the idea is that this is going to help you determine, one, how to interpret these laboratory values or help you on your exam. Now, how can we fix what could be some treatment options, right? For a low potassium level. Well, we got to find the cause. We got to work, we have to collaborate with doc and find the cause. Okay. Low potassium, the doctor may tell the patient that's going home, hey, if it's too low, you're going to grab that salt substitute that is full of potassium. What are some foods that are high in potassium? Bananas, pears, excuse me, fresh dried apricots, certain juices, tea, funny, tea, certain teas, um, fish, dried beans, baked potato, avocado, cantaloupe, tomato. A renal patient who has a risk of increasing their potassium because maybe they're in end-stage renal disease, you want to avoid those foods, right? Because remember, you have to treat the cause or decrease the risk for potential problems to the patient. So some of the treatments of hyperkalemia, if they're actually in the stage of hyperkalemia, they may give sodium bicarbonate, right? They may give that to alkalize the body or alkalinize the body. They may put them on dialysis, whether it's hemodialysis or peritoneal dialysis. We have to get that toxic level of potassium off the patient. They will give regular insulin in small doses. Remember, because if insulin's up, so is potassium. And they'll give that intravenously to aid in the transfer of glucose and potassium into cells, get it out of that extracellular fluid, bring it back, right? And of course, restricting dietary potassium. So you teach the renal compromised patients to avoid foods that are high in potassium, tomatoes, cantaloupes, avocados, and the list goes on. Okay, those you can research. But so hopefully this was a short and sweet way to help you understand serum potassium and what it could look like in the body and some of the certain changes you may see on an EKG strip. All right.